Welcome to Beyond the Prescription podcast. Today we have a special guest, Dr. Risa Hatten, and she is going to tell us about her passion on helping people that have struggled with past addictions and things like that. So we can't wait to dive deep into this.
Yeah.
Welcome.
Well, thank you.
I'm so glad you're here.
I'm glad to be here.
So tell us, I just know you because, well, I've done clinicals with you and you've delivered one of my babies and you've probably delivered a lot of babies around here. You are born and raised in Olney?
No.
Okay, so tell me a little about it.
Okay, I was born in a little tiny mining town called Man, West Virginia. My parents are from West Virginia.
Oh.
And my grandparents are from West Virginia. And my great-grandparents were from what was Virginia before the Civil War. So we've always kind of been in that part of the world. And my dad moved here in 1963, and it's kind of a fun story. He and my mom were in Springfield, Illinois, in an airport, and they had just flown out to Steamboat Springs, Colorado, to look that over. And my mother thought it was the ugliest town she'd ever seen in her life. And they were sitting back in Springfield, and they got into it talking with another couple. It was Dr. Paul Weber. So those of you who know the Weber Clinic.
Nice.
And my dad and Dr. Paul, he was also an OBGYN, hit it off. My mom and his wife, Ollie Mae, hit it off.
Aw.
They got in the car with the Webers, drove her to Olney, and bought a house. So,
and
yeah, that's how we ended up in
There
Olney.
you go. And that was in, in the 60s?
1963. Yeah.
Oh, wow. Very cool.
So I grew up here in 63 to 76, and then I went to college and then residency and off to Minnesota.
Yeah, that's what I was going to say. I knew you worked somewhere else.
Yeah, I went to University of Illinois, Champaign-Urbana. Go Illini. For 10 years, I did my undergrad, grad, and medical school there in Champaign-Urbana. And then I went to St. Paul Ramsey Medical Center in St. Paul. And then we lived in Minnesota for 25 years.
Okay.
So, yeah. Then moved back here in 2008.
In 2008. Okay. Very good. So you've been back here almost a big chunk.
Yeah.
So very good. Yeah. Well, let's say your wheelhouse in the beginning of what your primary focus has been on has been OBGYN.
OBGYN, yes.
But you also have a passion to help people with like addiction and things like that. So take us down that.
Okay. Well, it is a newfound passion. And this is, if you had asked me back in 1986 when I started my OBGYN residency, if I ever wanted to do addiction medicine, I would have told you absolutely not. Want nothing to do with it. Mm-hmm. I had a brother who struggled with addiction from the time he was 14. And he was very angry and very violent prone. Mm-hmm. And he made our house just so miserable growing up. He was like a tornado. And the last thing I wanted to do is be around a waiting room full of my brother. And I love my brother. Please don't get me wrong. I did. But I also hated him.
Yeah.
And so I was happy doing OBGYN. I was satisfied with that. Came back here doing OBGYN. But we started getting more and more patients on a medication called Suboxone, which I'd never heard of. I'd never learned about it in my medical training. And my patients were driving to Chicago to see specialists. They were driving to Chesterfield, which is a far western suburb of St. Louis. And I had one patient driving to Indy, and she had one time, it was terrible weather, she was pregnant, and there was a huge accident on the highway. She was not in the accident, but she was stuck on the highway for almost 2.5 hours in this accident, backup traffic. And she was like 38 weeks pregnant. And every time we would have staff meetings, the head of the program would say, hey, is anyone willing to, they'd say this to the family practice doctors and the internal medicine doctors, anyone willing to step up and do Suboxone, anyone willing to step up and help. And we were being told at our meetings, too, that overdose was the leading cause of maternal death in the state of Illinois. And one day, in just a fit of pique, I'm just like, I'll do it. And I sat back and thought, what did I do? What did I just say? I don't want to do this. I don't. And I started my training, and it was very frustrating at first because it wasn't well thought out the way they were having us approach the training to it. But once I got in the training process and I started going over to St. Louis and preceptoring with one of the psychiatrists and going up to a meeting in Chicago, suddenly it's just like, okay, I can do this. I think I can do this. You know, you get to an age when you don't want to learn more medicine, drug-drug interactions. You don't want to learn more side effects. You're just like, I've got all the medicines I'll ever want here in my nice, and I'll learn this new one. And I started seeing patients. And the third patient I ever saw was not pregnant. And this person was just didn't want to be here. She didn't want Suboxone. She wanted nothing to do with it. But her doctors had retired, and she couldn't find anyone else willing to write pain medicine for her. So she was, she'd been going out and buying it off the streets, and she just got tired of that. So she started seeing us, and she wouldn't make eye contact with me. She stared at the wall. She sat with her arms crossed. But by her third visit, she told my nurse that she was able to leave an abusive marriage because her husband was getting pain pills, and he would make her crawl to him to get them. Mm-hmm. And he would, if they were out in public and she disagreed with him, he would like elbow her or push her into a wall and then not give her the pain pills. And she said she put up with that for 26 years because she needed the pain pills, and now she was able to get off of them. And she went back to college. She got a job. I mean, it was just like we're sitting here thinking, well, that's going to be a one-off. No, we hear this story over and over that people get their lives changed. And suddenly it's just like I had so much stigma toward treating people who struggled with addiction because of my own experience. But that has not been my experience.
Yeah.
Once I just kind of opened myself up to, let's see what happens. And I began to realize addiction is such a crutch, or it's just such a burden on people. And if we can do anything to help, it just gives people their lives back. And we have a clinic full of people that we really have helped, and not everyone. It's not a 100% thing. But when you have people coming in that are happy and healthy and are able to spend more time with their family and their kids and have jobs that, they're productive in. They're happy, it makes you happy. So it's been a wonderful thing. I would not have believed this 7 years ago, and 3 months into practicing and providing this service, it opened my eyes. So
that's amazing. So I guess let's start with Suboxone, and it's not necessarily a new medication.
No.
Can you kind of give us a little bit of how does it work, and what are the things that, I guess, if you have addictions with, what it can help? Like you had mentioned the pain pills, and then I think there's some other drugs and things like that that can help with that.
Well, what's really interesting, I find, and this is the rabbit holes I go down, is when I was in graduate school in anatomy, I had to take a class that was a science class but not a anatomy class. And I ended up in a botany class for a very short time because grad level botany is really, really hard, but it's also very interesting. The opium poppies, and poppies grow everywhere. They're very, very pretty. When they lose their leaves and you're left with the poppy hip, like a rose hip, when they lose their leaves, and people make tea out of rose hips.
Okay.
You can scratch that poppy hip and this sap comes out, and they call it latex. It's not latex, but it's a sap, and that's what we get. That is opium.
Okay.
And in opium is codeine and morphine. Okay. All right. Tramadol, the medication that is low modal. And a medication from which we get buprenorphine, naloxone, and naltrexone. So the poppy plant gives us the push of morphine, the pull of naltrexone, and the middle ground of buprenorphine. So what morphine and codeine and all of the pain pills that are opiates, they came out later, or they're opioids, excuse me. All of these attach to something called the mu receptors in the brain.
Okay.
And the mu receptors, if you turn them up all the way, make you feel pretty darn good. They really do. If you use something like naltrexone, they pull those receptors, they turn that mu receptor all the way down. So if you're using fentanyl or something that's turned that receptor all the way up, naltrexone pulls it all the way down. That's Narcan. And that's what makes you feel, that takes you out of that high. So, people that unfortunately are having an overdose, they get the Narcan, they wake up swinging, and they're just now they're in total withdrawal because you've taken all the meds away. So
almost instantly.
No, it's pretty instantaneous.
Yeah.
And what buprenorphine does is it takes you to a middle ground. So instead of having that incredible high or that incredible low, it puts you in the middle.
Okay.
So if you are on buprenorphine, if you're taking a pain pill, they'll tell you not to drive, not to operate heavy equipment. If you're on Suboxone, you can do that because you're not impaired like those other medications do. You're not sleepy, you're not drowsy, you're not going to fall asleep, you're not going to quit breathing. It takes you to a middle ground. You can be a doctor, you can operate on it, you can do You can drive a car, you can drive a truck. I don't know about the astronaut training program. I haven't asked. But you can function just like you normally would.
And it's replacing what they have been using for so long, right?
Right. And it doesn't give you that. Some people say they take it to get high. If you do, it's a crappy high. It doesn't last very long. It doesn't take you as high as those other medications can. And for people that were using, I mean, I had one of my patients today refer to himself as a former dope fiend living in the gutter because he was just high all the time. He couldn't hold down a job. His family wouldn't let him live at home. He gets on the Suboxone and he suddenly is able to function. He's able to get a job, keep a job. And he says, no, I'm not high like I used to be, but I don't want to be like that anymore.
Right.
Because I kind of outlived that for 10 years.
Right.
So
let's say well, I guess let me start with, do you have anything off the top of your head of in regards to statistics in this area about opiate abuse?
I think methamphetamines are still the biggest drug that's abused. If you ever look at and I read the paper, I see who's getting arrested and for what, it's still methamphetamines are the big one. And Suboxone does not work for that. Methamphetamines and cocaine are stimulants. And what the Suboxone is working for is the opiates, like fentanyl and morphine. Well, morphine, no one's taking morphine, but like the hydrocodone, the oxycodone, all of those.
Does it do anything for heroin?
Yes, heroin is an opioid. It also attaches to the mu receptors.
Okay.
But most people don't use heroin anymore. It's fentanyl. Fentanyl took over because it's much more powerful, much cheaper. You can use just a teeny little bit and get the same results, so you don't have to make as much.
Okay. So what is a process? So let's say somebody listening has a loved one that has been struggling with, narcotic abuse, and that loved one is willing to maybe take a next step. What does it look like for a program?
What we do is if people call our office and we want to be seen, as soon as we can get them in, we'll get them in. But in the meantime, they can call. We give them a number called the Bridge Program, where they can talk to someone over the phone and they will help them get started. They'll talk to them about when they last used, how to start the Suboxone, how to take it. They'll give them a short-term prescription until they can get in to see me. In the beginning, we were kind of told that everyone that got Suboxone needed to get into counseling as well. They needed to see a mental health provider. They needed drug counseling. It's almost impossible to find that around here. Resources are very scarce here. I do not make people see a counselor or do counseling as a part of what I provide because I don't want to burden people unnecessarily. We encourage it.
Yeah.
But I've got a lot of people that say, I got 3 kids, I got a job, I don't have time. And I understand that too. So we once again, we encourage it. We encourage, even joining some support groups because it can help, but we don't make it just, it's not an absolute.
Okay. So they would come in. So I guess I want to start back on that Bridge Program. Is that a state of Illinois thing?
I think it's just a nationwide program.
Oh,
but yeah, the state of Illinois does fund one because, it all has to do, you can't write prescriptions across state borders. So if I get patients that come to me from Indiana and Vincennes does accept prescriptions for me because we're so close to the border. But if I tried to do it someone in Alabama, they wouldn't let me.
Okay, I see. So they come in and then are they going to have let's say, is there a certain time from the last time they have used the narcotic that they can start this?
We always talk to people, when do you notice you start having withdrawals? Because everyone is different. Everyone's body will metabolize it differently. And depending upon if you're using heroin, which can get out of your system quicker than fentanyl can. Fentanyl can last a long time. The worry is if you're on a high, a big time high, and I give you Suboxone, I can bring you down into major withdrawal before I can get you back up to a steady state. The Suboxone is that powerful. We joke that bupe is king. It will knock everything off of a receptor. So I almost want you in a little bit of withdrawal
before you start.
And sometimes people say, "Ooh, I'm not really willing to do that. It's withdrawal so hard." So we'll start them on teeny tiny little doses and just increase it slowly and steadily and just gradually wait for that fentanyl to wear off and that bupe to take its place. So we've changed how we do things. We don't make you be in big time horrible withdrawal before we start it.
Okay.
Although I'll tell you, I'll make you feel better if you are in withdrawal. The buprenorphine will make you feel better.
And so it's not they don't have to be inpatient and monitored.
No, nope. Not anymore.
Are you just seeing them pretty frequently? Why that's going on?
In the beginning, when I first started doing this just for my own comfort, I would have my people start the Suboxone in our clinic. We had a room, and we would give them, a small dose. We would check on them in a half an hour, and then an hour later give them the other half of the dose, and just slowly increase it like that while they were in our clinic. So, my nurse and I could both feel comfortable. I mean, anything new. After a while, we're letting people take it home and start at home. You just kind of learn that, hey, this is what I say to the internal medicine and family practice providers who just are like, oh, sorry about that. I don't want to get involved in this, is if you put people on a blood pressure medicine and then a heart rhythm medication and then a blood thinner, all three of those can kill people. Suboxone does not. Suboxone cannot kill people. So it is one of the safest medicines out there, and it will save lives. So it is so much easier than I ever thought it would be.
Okay.
And that's the main message I want to get out there to any practitioners thinking about providing this as a service. It's one of the easiest things you'll ever do.
Okay.
Truly.
And impactful for families.
Yes, it is. And it will make you will realize just what an incredible tool this is to help people who struggle with addiction.
Yeah, yeah. If they start with the program that you offer, is that do they come in once a month, or how does that work?
In the beginning, I do like to see people every month or sometimes every 2 weeks. In the very beginning, especially if they're unsure or if they're real nervous about it, we'll keep really close contact because we want them to succeed.
Right.
And we want them to feel comfortable with the whole process. I now have people I see every 3 months, and that's only because I have to. There are people I would see once a year that do so well on it and have done well on it. And there are other people that are more comfortable. Some people say, no, it's just like Weight Watchers. I want to come in and be held accountable. I want you,
That's good.
That's fine too. It's whatever makes the patient comfortable. And, sometimes too, and this you may find this too with your clients, patients will come in and say to us, you're the only people that are nice to us. And from our receptionist to, my nurses are wonderful. My pharmacy staff is wonderful. Some of the pharmacies around here are a little twitchy, and some of them are super kind and super receptive to this as an issue. So, some of our patients say it's just nice to come in and have someone look at me as a human being who struggles with addiction. Doesn't look at me as an addict. And that's one thing that we always try to push is I tell my patients, don't call yourself a drug fiend. Don't call yourself an addict. You need to quit calling yourself these names too.
Yeah, let's get that label off of you for sure, because it doesn't have to be like that. That's great. So is Suboxone considered controlled?
Yes.
Okay. So they have to come in and get or you have to send in a new prescription every month?
Every month.
Yeah.
Now, I just recently got something from one of the medical assistants, like a Meridian, I think it might have been Meridian, asking me why I'm not giving people 3 months prescriptions. I'm like, well, piece of paper, because you've never told me I could. And I do have patients that I don't know if that would be a good thing, because some people's lives are a little more scattershot than others. Some people don't have the ability to have these medications tucked away safely, that if they lost, if people lose a month's worth, insurance companies are super twitchy about, this is pain medicine. They're real twitchy about replacing it. You lose your blood pressure medicine,
whatever,
we'll refill it. You lose your birth control pills, we'll refill them. You lose your, controlled substances. So it's one thing if you lose 2 weeks worth. It's another thing if you lose 3 months worth. And
that's a good point.
It is, but it would be nice to be able to just send for a 3-month refill, or like a monthly refill for 3 months in a row, and not have to go through and enter all the code numbers we have to do.
Yeah, you mentioned insurance. Do you have problems with any certain insurances not covering? Do you see good coverage with all insurances?
I have seen good coverage except with the injectables. And there we have struggled with a couple of them. And it is always the pain in the butt for my nurses. They're the ones that deal with prior authorization, never the doctors. But even then we get them covered.
So whenever you said injection, so the pill is a daily pill?
Daily, it's 3 times a day.
Oh, three times a day.
And
wow.
These medications cannot be absorbed in your stomach. They have to absorb in your mucus membrane.
So it's just like a dissolving tablet?
You put it under your tongue. It's either a film Remember the little breath strips that were
Yeah.
they're like a film like that dissolve under your tongue, or they're a
Okay.
tablet that dissolves under your tongue.
Okay.
And it can take, I always tell my patients, 3, 5, 7, 10, 15, 17 minutes to dissolve. Everyone's mouth is moisture.
It's different,
Some
yeah.
people have really trouble with dry mouth. So it can take a while to dissolve. So you have to be patient with it. You don't smoke, you don't eat, you don't drink, you don't talk, you don't nothing while it dissolves. And they taste terrible.
Oh.
They taste terrible. And a lot of people, some people will put their full dose one time a day. Most people do it throughout the day, especially if they have chronic pain, because you do get some pain coverage using it
that.
throughout the day. And also, for some people, that's how often they used. So this kind of mimics that behavior, and it makes it easier. They're not trying to break too many habits at one time.
Okay. So with the injection, I know I've heard of the injection, but I don't know anything about it.
They're once a month.
Okay.
And right now there are 2 different brand names. There's the original one called, I don't know if I can use brand name, Sublocade, and the second one is Brixadi. It's the buprenorphine component in a gel matrix, and it's injected under your skin, and the gel dissolves slowly over time, and it releases the buprenorphine into your system. And they usually last about a month.
Do you switch people over to using the injections if they're, relapsing or anything like that? Or
We let it be their choice. And
Okay.
some people find it nicer to not have to take something 3 times a day that tastes horrible. I've got some people that have breathing problems, and they breathe through their mouth and it's really dry. So, for them, sometimes the injectables hurt. We always say it's a bee sting. Just suck it up because it's going to hurt. But some people like being free, especially if you're going to travel. You don't have to carry this medication with you. At work, you don't have to stop in the middle of the day to take it. It's just really convenient.
Yeah.
But it's not for everybody. I've had patients that didn't like it, not just because it hurt. They just didn't feel they got the good effect from it.
they'd rather have the 3 times a day.
Yeah. And I've got people that say, hey, I was a needle junkie. I like the feel of the needle, so I'm going to avoid that.
Okay.
So,
Yeah.
Things I never knew existed.
Yeah. I mean, I would agree with that. I even have patients, that I mean, I don't do the Suboxone, but like just for another reasons, they've came in and they're just like, I can't be around syringes.
Yeah.
You know what I mean? And that's like something that's like completely opened my eyes of like something that I have never personally struggled with, but I struggle with other things, but just like that fact of being around syringes.
And, it's one of those things that on a day-by-day basis, I probably never would have thought of.
Right.
But when they tell me that, I'm like, that makes sense.
Yeah, absolutely. For sure. Do you see relapses very often? Do you see, what do you do when that happens?
Well, in the beginning, it's. I always tell people, if you find that you stumble, come back. We don't judge you. We don't get mad. We get mad if you don't come back.
Yeah.
We get mad if you think I'm going to be mad, because we're only here to help. We are not here to punish ever. We are just here to help. And people will have hiccups in the giddy up for a variety of reasons.
Yeah.
And the longer you've been on the Suboxone, the easier it is to avoid the temptations. But one of the things they tell people when you get out of rehab is move. Get away from all the people that you used with, leave those environments. Well, not everyone can pick up and move. And what do you do when you use with your sister? What do you do when you use with your dad? What do you do when it's family?
Yeah.
What if it's your spouse? I mean, sometimes you don't have that. And some people, I've had them say, my husband got in a car accident. He had all sorts of pain pills laying around. I made him put them in his top drawer. I didn't walk on that side of the bedroom. I mean, and they say that may sound silly because it's 4 feet away, but to just avoid that 4 feet made it easier to avoid. So, when people come in and they say, hey, I was tempted, we walk through it, we talk through it. And that's where counseling can help too, or to have a sponsor that you can call and say, hey, I was so close to, and have the sponsor say, well, here's how I dealt with that same thing. Do I think you have to have used substances to treat substance abuse? No, I don't. But I think it can help. It really can have a perspective. But, one of the meanest OB-GYNs I ever worked with was a woman. So when patients would say, oh, these labor pains hurt, she would argue with them that hers were worse. So, I don't think it's necessary. I think empathy is necessary.
Yeah,
and
absolutely.
a willingness to listen.
That's really great. Is there anything that has to be monitored in regards to like labs or anything like that, or is it just general labs?
The clinic that I work at requires us to do a urine drug screen on everybody. Once again, I don't use these to punish people. I have fired people from my practice for never having the medication in their system because I know they're selling it. And we just say, 3 times, and we give them
3
fair
strikes
warning.
are out. Yeah.
And I'm not, once again, I don't want to punish people, but 3 times in a row, and when I've talked to you about it, I'm just like, number one, you're getting Suboxone out there, and hopefully people are getting a good effect and wanting. I mean, it is one of my best advertisings. It's like baking cookies and letting people let their friends try them and saying, yeah, I'm going to come in and get some of those cookies. At the same time, I don't listen. When people come in and say I buy it off the street, sometimes we'll stalk them on Facebook and see who's friends with who, and I'm like, yeah, I know who you're getting this from. I don't care because you're here, you came in,
Right.
now you're going to get hopefully some relief from the struggles you have, but. Once again, I don't call people out. We just say, sometimes we'll say, hey, what's going on? I've noticed that you have this, or, hey, watch out. These things are laced with fentanyl. You got to, try to keep yourself safe. Please keep yourself safe.
Yeah, and that's a big thing right now with the lacing of the fentanyl, right? And the overdosing because of that. Yeah,
it's terrible.
Yeah. The other thing that I was just wondering about in regards to counseling, you said you don't mandate it, but for resources around here, like sometimes we're waiting 4 months to get in for counseling and things like that. And then do we have anybody that specializes in substance abuse counseling here?
I think the Jasper County Health Department does, and I know Lawrence Health Department does.
Okay, good.
And I also tell people too, you can get online. You can join support groups online. So you can join a support group in California where no one knows you. If anonymity is a thing, and it can be, join a support group in Puerto Rico where no one knows who you are, and just you can talk to people, you can share, and you can buzz in and buzz out. So there's say what you will about Facebook. There are always support groups on there that you can join.
You can help, or that can help you. Yeah. So we all know kind of that addiction affects everyone. Doesn't matter, who you are, what type of lifestyle you have, whatever. It affects everyone. And I don't know really any family that hasn't been impacted by some form of addiction, whether it be narcotics or alcohol or whatever it may be. So I really do think that you are doing amazing things. I know that I have patients that are in your program, and they also just voice of like how they have a life.
Yeah.
And it's just a beautiful thing. And like I just think about all these years of this narcotic abuse and all this stuff, of all these families that were impacted and all these people that were impacted, and how this can just get them back on their feet, and it's.
And one thing we say too is it's never too late.
Yeah.
Anyone can change. And just because it's gone on a long time doesn't mean it has to keep going on for even longer time. And I think people sometimes do get down on themselves, and they'll say, well, I'm beyond help. It's like, no, not really. It's just come in and let us try. We're always glad to see what we can do, to help. And it's also, when I talk to my patients about this, I don't know what people realize, that if you're using pain pills or if you're buying fentanyl, you're not going to Costco on a Saturday afternoon and getting this stuff.
Yeah.
You're getting out at night. You're leaving your kids home alone. You are going into neighborhoods where most of us would not willingly go.
Yeah.
You are dealing with people that most of us would not willingly deal with. You're carrying cash. It's not safe. Although a lot of these, people that deal in it like the money coming in, so they make it a smooth and easy transition or transaction. But it's the anxiety of trying to find these substances, going out where you need to go, spending the amount of money you spend. And the one thing people say is, for the first time in a long time, I have money to take my kids to Disney World. The amount of money they save not spending it on these things.
Right.
I don't have to go out at night. I can stay home. I can feel safe. It's like, that's a glorious thing too.
Yeah,
Peace
absolutely.
is a glorious thing.
Yeah.
In your heart. So.
So if you had to leave like one thing for the community, the listeners here, for our community in Richland County and then the surrounding counties, like what would it be? You might have even already touched on it, but if you have, just what would it be that you'd want to leave for them?
I think one thing that I hear over and over and over in my patients' stories of, how did this start? How because we do ask. We ask, how did it start? What have you used? The amount of childhood trauma that leads to people wanting to do something to make themselves feel better is, you would be shocked. You would be shocked with how many people are hurting.
Yeah.
And the number of people that are injured young and end up on these medications and keep injuring. Sports are a great thing. Hey, but people will play injured and keep getting injured and not rehab enough. Just the number of people that are hurting physically and in their psyche. And I think that, I hear over and over, well, good, let them die of the overdose, or, they're just a bunch of addict bums. If they're on Suboxone, they're still using. We need to back up. We need to take a deep breath, and we need to say, this could be any of us.
Yeah.
This could be, like you said, most of us have family members or friends that we know have struggled. And it, what do I always say? There, but by the grace of God go I. And I think that we need to stop and give these people just a listen. And they might not come out and tell you why they use. It might be any of your dang business. But at the same time, I think we all just need to stop and take a deep breath and show some kindness and just look at the human behind the struggle.
Right.
So that's what I would ask people is just be kind.
Yeah. Yeah. And just speaking about like on a personal thing. So I was married at a young age, and my ex-husband had a football injury, and he went to sports medicine, had surgery, and he was prescribed narcotics. And that was it for him, and it was just a downhill slide.
Yep.
And it's just like you said, it can be anybody. Like he didn't have any of that in his family, like any abuse or anything like that. But you get prescribed that one medicine, and if you don't have the resources, or if you don't feel like that you can talk to people, there you go.
And these medications affect everyone differently too. Some people may take 2 of the narcotics after a knee surgery and be done with it, and other people are hooked by the second one.
Exactly.
And it's our bodies metabolize these things differently, and
yeah. So I just want to say thank you so much for coming in. You're
welcome.
Taught me so much. I know about Suboxone, but just like all of the little tips and everything that you're giving us, and your heart for it is awesome.
Well, once again, I never would have guessed this about myself, so I was pleasantly surprised to see that I can change.
Yeah.
So
yeah. And just for our listeners, I just wanted to share a little bit, but I was doing my clinicals with you. And we were in OBGYN and doing my clinicals, and we were doing some like female exams and things like that. And we were doing just a routine PAP or whatever. And I said, I'm really having problems and I can't really do the full PAP. And what you told me, and I've applied this to my life, and you said, the only thing I'm going to go do is I'm going to go in there and try harder than you. And so I was like, okay, well, I'm going to go in there and try harder then. And so I've always, I've taken that and kind of applied it into a lot of things of, maybe we just need to give it a little bit more for a little bit more try. So,
well, and I think that when you're learning, you're always afraid you're going to hurt somebody.
Yeah.
And I think that we all get a little hesitant. So sometimes it's just, and that was, I remember just talking to a family practice doctor one time when a patient had a uterus turned inside out, and he was after delivery, and it is an OB catastrophe. It really is. And he, I came in and I put the uterus back in place, and he said, I tried, I pushed. I said, yeah, and Arnie, I pushed harder. There's nothing magic. I didn't come in and have a certain position. I held my hands. Yeah. I was just willing to push hard. Yeah. And as I told him too, I can surgically fix anything I break if I do that. He didn't have that ability, so he was a little more timid. And so Yeah, I do say that.
So we thank you for the listeners for Beyond the Prescription for tuning in today. And we just want to encourage you that if you know someone or yourself that struggles with any type of narcotic abuse or anything like that, there are resources. There's resources in this community. We will leave some information on how you can get hooked up with this. And we don't want you or anyone in your family to struggle. And we want to help you thrive in all that we can. So thanks for joining in today. And just reach out to us if you have any questions.